My presentation today about cardiac disease in pregnancy, prenatal care management strategy. Of course, the incidence and changing pattern of heart disease, it ranges from 0.1 to 4%. Hospital statistics, industrialized countries have shown a decrease in the incidence from heart disease with pregnancy from 0.9 to 0.3%. But there is sharp decline in the incidence of chronic rheumatic disease, heart disorders, fortunately, with advances in the medical and surgical treatment of patients with congenital heart defects has resulted, of course, in an increased survival to reproductive age. Maternal mortality from heart disease. Statistics have demonstrated a decline in maternal mortality from cardiac disease since 1950 to from 5.6 to 0.3 per 100,000 births because of improved medical care of the pregnant cardiac patient with a sharp decrease in the incidence of rheumatic heart disease. What about cardiovascular physiology of pregnancy? Normal pregnancy is associated with an increase of 30 to 50% in blood volume. Blood volume increases starting at the 6th week and rising rapidly until mid-pregnancy. The levels peak by 20 to 24 weeks of pregnancy and then are either sustained until term or decrease. An estrogen-mediated stimulation of the renin-angiotensin system results in sodium and water retention, appears to be the mechanism underlying the blood volume increase. Of course, the increase in cardiac output is the most significant change during pregnancy. It begins to rise in the first trimester and steadily rise to peak at 32 weeks by 30 to 50%. Cardiac output is normally 4.2 liter per minute, is 6.5 liter per minute at 8 to 10 weeks of pregnancy and remains so till near term. Increase in cardiac output is achieved by rising stroke volume in early pregnancy and heart rate in the later part of pregnancy, adjusting together. So we have increase in cardiac output by rising stroke volume. There is increase in cardiac output, but in the early pregnancy it is increased by stroke volume, and in the later part of pregnancy it is increased by the heart rate, which is important. Cardiovascular physiology of pregnancy. Due to rise in endogenous circulating catecholamine, there is positive inotropic and chronotropic myocardial response. Later in pregnancy, the rise is related to an acceleration of heart rate by 25%, since stroke volume decreases as a result of vena cava compression. This is very important, as we can see. This is a very amazing showing what we have said. The physiological changes in pregnancy. Blood pressure remains almost to pre-pregnant levels, except a tendency to fall during pregnancy, particularly during the mid-trimester, as the systemic vascular peripheral resistance falls. Why this happens? Because due to the large arteriovenous shunts at the placental bed and physiological vasodilatation secondary to endothelial prostacyclin and circulating progesterone. Simulating cardiac diseases. Of course, we have discussed now the normal changes. These may lead to some sort of dyspnea, to fatigue, to lightheadedness. So owing to these normal changes, many healthy pregnant women have symptoms mimicking those of cardiac disease, like fatigue, dyspnea, lightheadedness, number of abnormal findings of physical examination, and ECG and echocardiography. Some physiological changes of pregnancy that mimic symptoms and signs of cardiac disease may be tiredness, coming of dyspnea, orthopnea, syncope, lightheadedness. You may have peripheral edema. You may have distended neck veins, prominent A and V waves, brisk diffuse displaced left ventricular impulse, palpable right ventricular impulse, persistent splitting of the S2, early ejection systolic murmur, maybe mammary souffle, of course, pulmonary area, maybe cervical venous hum. All these you can have in the ECG left axis deviation. You can have cystity even changes. You can have a small q, inverted P, or T wave in lead. So this is very amazing, wide array of changes even in the ECG. Increased R wave amplitude in lead 2, atrial ventricular ectopics. You can have even chest x-rays treating left upper cardiac border. You can have horizontal heart position. You have increased lung markings. You can have echocardiogram, increased right ventricle, left ventricle dimension, even mild increase in left-right atrial size, slightly improved left ventricular systolic function. You can have functional tricuspid pulmonary insufficiency. It may have small pericardial effusion. All these lead to some changes, as we can see. So if you can, how to differentiate from common signs and symptoms and normal pregnancy versus those who are abnormal? By different parameters. Maybe by the history of heart disease, by the chest pain, by palpitation, by syncope, fatigue, vital signs, physical examination, GVP. All are different. You should just take. This is very important to look for the difference. So management areas to be considered: risk stratification, look antepartum management, peripartum management, recurrence of congenital lesion in the neonate, site of antepartum, peripartum care. So we mainly have preconception counseling. This is important aspect of management. Ideally, the obstetrician and the cardiologist should work together to help the patient make an informed decision, prevent an unwanted pregnancy, avoid the risk associated with pregnancy. Risk assessment. If she's complaining of NIHA class 2, 3, or 4 dyspnea or cyanosis, she's having left ventricular systolic dysfunction with ejection fraction less than 40, she's having left ventricular obstruction, mitral valve area maybe less than 2, aortic valve area less than 1.5, or peak left ventricular outflow tract gradient more than 30 millimeter mercury, a cardiac event, arrhythmia, stroke, transient ischemic attack, or pulmonary edema before pregnancy, but since a prior cardiac surgical procedure. There is, as you develop a risk index incorporating these factors in a women with a heart disease with no other risk factors, likelihood of cardiac event during pregnancy 5% around. It may increase to 25% if she has one risk factor. It may increase to 75% with more than one risk factor. This is very important. Maternal mortality with cardiac disease. Actually, there are different cardiac diseases, but the range of associated mortality ranges from 1% up to 50%. Less than 1% in ASD, VSD, PDA, pulmonary valve tricuspid disease, corrected tetralogy of valve, bioprosthetic valve, mitral stenosis with class NIHA 1, 2. But if there is coarctation of the aorta without valvular involvement, uncorrected tetralogy of valve, Marfan syndrome with normal aorta, mechanical prosthetic valve, mitral stenosis with AF or NIHA class 3 or 4, aortic stenosis, previous MI, actually the associated mortality risk may increase up to 15%. But if she's pulmonary hypertension, look for that pulmonary hypertension, primary or secondary, coarctation of the aorta with valvular involvement, Marfan syndrome with aortic involvement, peripartum cardiomyopathy, uncomplicated. Actually, this may lead to 50% increase in mortality. A careful history is obtained. A patient with functional class NIHA is very important. As we said, if it is more than 2, this is very important. And this, we all know the class, New York Heart Association functional classification. Antepartum care, you should keep the patient within her cardiac reserve. While it's preferable to have detailed baseline information. Limiting activity is helpful in severely affected women with ventricular dysfunction. If she has left ventricular obstruction, she's having class 3 or 4 symptoms, she has hospital admission by mid-second trimester. Problems should be identified early and treated aggressively, especially pregnancy-induced hypertension, hyperthyroidism, infection, and anemia. We can give, of course, antibiotic prophylaxis for high-risk women undergoing genitourinary or gastrointestinal procedures. You can give ampicillin, you can give other forms, as we know, in high-risk patients who has penicillin allergy. We can use vancomycin, for example. FDA classification of drugs during pregnancy. We know XA, it's controlled studies with no risk. B, no evidence in risk in humans. Risk is not excluded. C, D, positive evidence for risk. X is contraindicated. Beta blocker rather than digoxin should be used to control the heart rate for patients with functionally significant mitral stenosis. You can use empiric therapy with beta blockers in some patients with coarctation, Marfan syndrome, ascending aortopathy, or other reasons, bicuspid aortic valve, for example. Management strategies in pregnant women with aortopathy is very important because if you have Marfan syndrome with a normal sized aorta, you can deliver higher by delivery by vagina. If it's dilated more than 40, you can, but again, if it is less than 40 millimeters by vagina. If the ascending aorta from 40 to 45 millimeter, you can deliver a cesarean. If it is more than 45, oh, take care that you should, you can do even prophylactic aortic surgery before or during pregnancy for rapid growth. And of course, at this situation, you should deliver her by cesarean. What about bicuspid aortic valve? If it is ascending aorta less than 45 millimeter by vaginal delivery, 45 to 50 by cesarean, at more than 50, of course, cesarean. Also, aortic surgery before or during pregnancy, you can do it, even if it is more than 50 millimeter. Arrhythmias, premature atrial or ventricular beats are common in normal pregnancy, and in patients with pre-existing arrhythmia, pregnancy may exacerbate their frequency and hemodynamic severity. Usually, they are not treated. Antepartum care, those patients having atrial flutter or AF should be treated promptly. If possible, all antiarrhythmic drugs should be avoided during the first trimester, and those known to be teratogenic should be avoided throughout pregnancy. Of course, the safety profile goes to digoxin, beta blocker, adenosine. These are partially safe. And look for the management of valvular heart disease. You can use beta blockers, metoprolol, class C, atenolol, class D. Either is preferred over propranolol. Mitral regurgitation, you can use diuretics. You can use are rare. You can use some diuretics as well. Aortic stenosis, you can use beta blocker. Aortic regurgitation, you can use dilators and some vasodilators. Anticoagulation therapy. No current end strategy is equally safe for both mother and we can oral therapy with warfarin is effective, logistically easy. However, it can affect embryonic organ development, although some evidence show that a dosage of 5 milligram per day may not be teratogenic. We can, fetal intracranial bleeding is a risk factor during pregnancy, especially during vaginal delivery. Unless warfarin is stopped before labor, heparin is adjusted in subcutaneous doses, does not cross the placenta, and so has no teratogenic effect. However, it may cause maternal thrombocytopenia, and we know all this may happen. It may cause osteoporosis, less effective in preventing thrombosis in patients with prosthetic valve, as we all know. Anticoagulation therapy, adjusted dose heparin during entire pregnancy, or adjusted dose heparin until the 13th weeks of gestation, and then you start warfarin from the 14th week to middle of the third trimester, then restart again adjusted dose heparin. You can use low molecular weight heparin in adjusted doses, is easier to administer and has been suggested as an alternative to adjusted dose unfractionated heparin. At week 36, pregnancy, discontinue warfarin and change to unfractionated heparin. At delivery, restart heparin therapy 4 to 6 hours after delivery if no contraindication, and you can resume back warfarin the night after delivery if no bleeding complications. You monitor low molecular weight heparin twice daily, maintain levels nicely with dose adjusted unfractionated heparin. The APTT should be at least twice controlled. Dose and warfarin INR should be 3. Cesarean section indicated only for the following conditions: the patients with aortic dissection, Marfan syndrome with dilated aortic root, taking warfarin within 2 weeks of labor, and preterm induction is uncommon. However, once fetal lung maturity is assured, a planned induction and delivery may be warranted for high-risk patients to ensure that appropriate staff and equipment are available. It is not routine to give endocarditis prophylaxis by antibiotic because it is not proven by many people. Positioning the patient for the left side lessens the hemodynamic fluctuations associated with contraction with the patient is supine. This is very important. Forceps or vacuum extraction should be considered at the end of the second stage of labor to shorten the delivery. Postpartum, because hemodynamics do not return to baseline for many days after delivery, patients at intermediate or high risk may require monitoring for around 72 hours. Take care, 72 hours postpartum. Lactation should be encouraged unless the patient is in failure. Cardiac output is not compromised during lactation. Lactation is a pathway fluid excretion. Take care. Lactation is the pathway fluid excretion. No problem with as long as the patient, it should be encouraged as long as the patient can, as long as the patient is not in failure. Diuretic requirement may actually fall. Contraception barrier methods are unreliable. Progesterone-only pill have better side effects profile. Sterilization when family completed, and conclusion is pregnancy causes significant hemodynamic changes and imposes an additional burden on the cardiac patient, especially around the time of labor and in immediate period to achieve a successful pregnancy outcome. A clear understanding of these hemodynamic adaptations, as well as meticulous maternal and fetal surveillance for risk factors and complications throughout the pregnancy is essential. We should use appropriate contraception, family planning, concerned, of course, that we should have a team. And thank you very much.